Thanks, Margie. Thanks for the introduction, and thanks for having us here again online. I wish it was in person. I really can't wait for that, but hopefully this is the last year. I'm just going to get started, and then Eric is really going to talk about the actual content of this talk. So can we go to the next slide? I think all of the attendees here know what adrenoleukodystrophy is, so we're not going to talk about it, but as you all know, it has different presentations, and the most devastating form is the childhood cerebral ALD. And I have here on the left side just a plot to illustrate the reason why newborn screening in ALD is so critical. This depicts the rate of disease progression in terms of major functional disabilities that these children acquire once they have MRI changes past a certain point, a LES score of greater than 10 with a positive gadolinium scan. So this is typically around the time when they start showing perhaps their first symptoms. So when you see that, it's too late for transplantation. And you can see here that within about a year, most of them either progress to a score that is basically death or are extremely disabled in a vegetative state. And so we can stop that by identifying them before they develop MRI change, neurologic symptoms when they just develop early MRI changes. And another key thing that has happened in the ALD field this year is that while the paper on reporting the interim results of a ex vivo gene therapy for ALD came out several years ago, that's shown here, the FDA had concerns about efficacy and safety, and a public advisory committee was put together that met last month, and they unanimously endorsed gene therapy for childhood cerebral ALD. The FDA still has not approved the product, but we'll make a decision in September. But we are optimistic that given the advisory committee's recommendation, that the medical officers will make the right decision and follow suit. So we have the allogeneic bone marrow transplant that's been already standard of care. And now with gene therapy, ex vivo lentiviral gene transplantation, we have basically two methods of intervention that are effective. And that's why we need to have newborn screening. So I'm gonna pass over to Eric, who's gonna talk about what's been happening on that front.
Great, thank you. Go to the next slide, please. So, but we're charged with giving the update for newborn screening for ALD. So the map over there on the left, and this was put together by the ALD Alliance, Elisa Seeger and Miranda McAuliffe. The map over there on the left is what the status of newborn screening was back in 2016. The map on the right is what I presented last year. Notice that a lot of the areas have filled in green, and last year, the reported number was about 65% of all births per year were covered by ALD newborn screening, and that was done through incredible efforts through advocacy at the state and federal level. So if we can go to the next slide. So you'll notice a lot more of the country is filled in green. So at the moment, 29 states are screening for ALD, which is a jump from 23 from last year. And if you look over to the left there, so there are a bunch of states that are listed in red that are expected to start screening by the end of 2022. Listed at the bottom is a CDC grant that's been applied for to help make all of the states RUSP compliant. And that again is done through advocacy. And us as investigators are trying to support these efforts as much as possible. So great strides have been made really in the past 6 years. Next slide, please. So just as a review for patients with XALD who are identified by newborn screening, what are we looking for? The slide that Ali presented, the first slide where he showed how patients become neurologically devastated from their index scan. Those are patients who are identified prior to newborn screening when their lesions are very big. What we're looking for on newborn screening on the panel to the left are these tiny little white matter hyperintensities that you'll notice in the first column. I don't know if you can see my pointer here, but these tiny little hyperintensities in the first row, and then again in the second row, where it's notably in the gene of the corpus callosum, white matter hyperintensities sort of at the top. So that's what we're looking for on newborn screening. How do we go about screening? There was a large consortium that was put together to try to understand the age distribution, which will then inform how often we perform MRI screening, and that was published in the Journal of Inherited Metabolic Disease last year. It's listed there. Notably, this is a meta-analysis of 30 years of published literature, mixed early symptomatic and pre-symptomatic patients. We came up with almost 1,200 cases, found that the mean age of diagnosis, at least traditionally, was close to 8 years old. The median age is around 7. I want the audience to remember the median age there, and to remember that age distribution, again, were both pre-symptomatic and early symptomatic cases pulled from the literature going back 30 years. And we use that to try to inform how do we go about performing MRIs for patients. Next slide, please. So that's where we were. What I'd like to talk about really in this update is, okay, we have newborn screening, what now? As an asymptomatic patient is identified, what have we learned? Well, how old are the patients developing cerebral lesions who are identified early on? We're learning a lot about how early cerebral lesions appear and evolve over time. So how long does it take for a small demyelinating lesion that's captured on MRI? If it doesn't show enhancement or evidence of blood-brain barrier breakdown, how long does that take? What do we expect? Traditionally, how long has it taken to treat a pre-symptomatic patient? And some of these are getting at what this pre-symptomatic window looks like that we talk about often in cerebral ALD. And really, number 4 is I think at the forefront of all of our minds, and this goes back to what Dr. Gill was just discussing. We're identifying patients with a disorder for which they're asymptomatic for the first 0 to potentially 20 years of their lives. 30 to 40% of kids will develop cerebral disease. And if it becomes clinically apparent, we think it shows up clinically, 4, 5, 6, 7, 8, 9 years old. But in the era of newborn screening, we are picking up variants of uncertain significance in boys who screened positive and may have borderline very long chain fatty acid levels. And some of these variants have never been reported to be associated with symptomatic adrenoleukodystrophy in the literature. So what do we do with these boys? Is it that they don't have ALD, or is it prior to newborn screening, there are a lot of mildly symptomatic men walking around out there who have pathogenic variants, but their phenotype is very mild. So this is what we're thinking about investigating. So if we can go to the next slide, please. So this is published ahead of print, but this is coming out in Neurology. We looked at 70 plus cases of pre-symptomatic cerebral ALD, and we asked a couple simple questions. How old were the kids when they first developed the cerebral lesion? So the median onset from the meta-analysis was 7. The median age of pre-symptomatic CCALD from this historical cohort, which is mixed retrospective and cases that were followed from newborn screening, was 6.4 years old. So about half a year earlier. If we look at the subset of patients who were diagnosed with a less score of 1 or less, so they have tiny cerebral lesions identified at MRI, those boys were identified under 6 at 5.8 years old. So really a year earlier, or a year plus earlier than the published literature would tell us. So this is probably where we're really looking to identify boys pre-symptomatically with cerebral ALD. So can we go to the next slide, please? So what happened with their MRIs? What did we learn? So the boys that were identified pre-symptomatically, half of them had enhancement at their first MRI, that age distribution there. And those are the boys that went to transplant or, would go to transplant immediately. But half of the patients had a T2 lesion, but no evidence of enhancement. So the question became, well, how long does it take to show up? The median time to developing enhancement is 6 months. So 75% of patients with pre-symptomatic cerebral ALD will have enhancement either at diagnosis or within 6 months. So this sort of informs how we will change our surveillance protocol once a patient's identified, to then doing close interim follow-up. One thing we learned is some cases, patients developed an enhancing lesion, went to get their pre-transplant MRI, the lesion shut back off, and then it turned back on a couple months later. So we're seeing this flickering effect, which has now been corroborated independently by some other colleagues. So learning a lot about the early evolution of cerebral ALD. Next slide, please. So the next question was, okay, from the time you had your first enhancing lesion, how long did it take really to treat the patient? So the median time to treatment from enhancement, so your MRI shows inflammation, was 3.8 months. And thankfully, 96% of the patients remained pre-symptomatic. If we look at, this is from enhancement to treatment. If we look at from the very first diagnostic MRI, your first MRI shows up with a cerebral lesion, to the time a patient was treated, it's about 7.5 months. That's the whole cohort together. And interestingly and importantly, that number, which I should have put in the presentation, but I didn't, was independently validated by Josh Bokowski's group. He looked at a different set of cerebral ALD kids from the time of their first diagnostic MRI to treatment, using a totally different scientific method, using pretty much a bioinformatics method by querying the FIS database. And he came up with the exact same number. So we're getting a nice piece of validated data here. So we've started to understand, now that newborn screening is in place, how much time do we really have to get the patients from their MRI, if it doesn't show up with enhancement and evidence of inflammation, when do we expect that to show up? And then based on when that definitively happens, how long do we have to treat the patient? So that's what we've sort of put out for the early natural history. Next slide, please. But this is more important, I think. So as everyone knows, Stefan Kemp, or may know, manages the ALD mutation, or now we call it the variant, ABCD1 variant database, where he's been painstakingly annotating every known variant published either in the literature or across known databases for the past 20 plus years. So we published an updated paper reviewing all the known variants. What you see mapped out there are the missense variants across each exon and where they live. And the bars in B, C, D, and E are each exon, and they're color coded to correspond with which part of the ABCD1 protein that piece of the exon codes for. But what we're finding is, and this is what I was alluding to earlier, now that we're doing newborn screening, it has been the case, and I've seen this in the clinic in New York, where we have a boy who screens positive through newborn screening, gets sequencing done, has a variant of uncertain significance, and maybe mildly or elevated VLCFAs. The issue is, of course, early in ALD, the patients don't have a phenotype. So you need the biochemistry. I agree wholeheartedly that neither the DNA people or the biochemical people can exist in silos. You need the biochemistry. And even then, in some of the pre-symptomatic cases, having VUSs with mildly abnormal biochemistry, we're stuck trying to interpret these VUSs as they're called. So if you look in this top row here, looking at C26 levels, the blue on the right are the symptomatic known ALD patients. The controls are over here on the left. And then you have these variants of uncertain significance that do something to the biochemistry, but do they push it into the ALD range? I don't know. But I do think we are going down the road of we may be able to think a little bit about genotype, phenotype, albeit being at the really mildly symptomatic ends of the spectrum. So Dr. Kemp and Dr. Orsini and Dr. Bonkowski are starting to think about, well, can we look at a bunch of these VUSs, try to find elderly male patients who have them, i.e. grandpa, see if, and take more in-depth family histories to try to understand, are there mild variants, which will effectively change how we monitor some of these cases. So all of this is needed, as is participation. So once you have newborn screening for a disorder, here come all the conundrums that come up, and hopefully these investigations will help us refine our understanding of the disease over time. I think that's all I have for the update.